Thank you. I think just to follow up on Chitra's talk, how I deal with my unhappy post-operative patients. I think the most important factor is to the pre-operative counseling, where you always tend to under-promise and over-deliver. What we are not talking about is bombastic words like throwaway glasses, but what we tell to the patients is less dependence on glasses if you're considering a multifocal intraocular lenses. Obviously, you would explain about dysphotopsia, tell them that bilateral surgery would enhance the quality of vision that these patients enjoy. In case, as was seen earlier, in case there is a suboptimal outcome, a touch-up procedure might be needed, which we obviously do free of cost. Then neural adaptation, which will be my last slide, is also the challenge as well as the friend for us in these situations. What exactly are the causes of dissatisfaction of these patients? I often say that it's 5 C's. Often we allude it to the sixth C, that's a crazy patient. But that's because of inadequate understanding of the problems that these patients have. Once you look at it deeply, most often you are able to identify the cause, at least mitigate it to some extent, even if not do away with it completely. I'm not going to be dealing with residual refractive errors because the earlier speaker just spoke to us about it. But one of the determinants which causes a significant deterioration of vision is the posterior capsular opacification. And ideally, you wait for a period of 3 to 6 months and create an opening like this to open up the capsule. And before doing this, it's always a good idea to ensure that it's not the lens per se which is the cause for dissatisfaction. And if in case a IOL exchange might be contemplated, it's better not to open up the capsule. Obviously, it's a no-brainer as far as a capsular thickening like this is concerned. But what about a situation like this? Especially if it's a multifocal intraocular lens, these are two eyes of the same patient that I had done. There's an excellent rexis overlap. Here there's a sort of a rexis runoff, because of which about 6 months down the line, you can see the patient was still reading 6.6, but he was not quite happy with the quality of vision, constantly comparing with the other eye. Even a diaphanous PCO like this causes a deterioration, and your threshold for doing a YAC capsulotomy, these patients have to be quite low. And once you have checked the retina, made sure it's fine, and go ahead and do this, you would often find that a simple YAC capsulotomy does enhance the quality of vision that these patients have. One factor which we do not often talk about, we do not concentrate on, is the centration of the intraocular lens. As you can see, again, bilateral implantation of the patient, and you can see because of the diffractive rings that are there here, you can notice the excellent centration of this lens. On the other hand, this lens is decentered. That's again because of the capsular rexis overlap being inappropriate. And in these situations, because the induced coma, especially with the multifocal diffractive lens, if you have a situation like this, the quality of vision would be quite compromised. And here, of course, if the capsular rexis margin is quite intact and it's possible to reposition the lens by doing a surgical recentration, that would be the procedure of choice. What has also been suggested is laser spots being placed in the periphery of the eye, in the close to the pupillary area. This causes shrinkage of the iris and draws the pupil in this direction. I've just done it in 2 eyes, and there's significant amount of pain, irregular pupil at the end of the surgery, and quite a bit of pigment dispersal. So obviously, it's not a great way to do. Prevention is the best way, and it's always important, especially if you're dealing with a premium IOL, to ensure that the intraocular lens is well centered straight away. Severe negative dysphotopsia, that's nothing else than the patient complaining of a shadow on the temporal aspect. And this is there are several ways of dealing with it. One is a YAC capsulotomy to the nasal ridge, or you can place a neodymium ND ring on top of this lens. In this case, which is operated by a colleague of mine, as you can see, it's an excellent toric intraocular lens implantation. The lawyer by profession has a 6.6 visual acuity, persistently complained of dysphotopsia, because of which 6 months down the line, after counseling the patient, we went ahead and placed a sulcoflex lens. This can come even in a zero diopter lens, and as you can see, you need about a 2.8 to a 3 millimeter incision in this, and this is the lens which goes in. It's a 6.5 millimeter. The most important aspect that it's a round edge optic, and it's a 14 millimeter overall diameter, because of which, and so as you can see, it's a undulating haptics, because of which it stabilizes nicely in the sulcus. And since this overrides the square edge optic of the primary lens, and the material itself is hydrophilic acrylic, the cause of the negative dysphotopsia is supposed to be from the capsulorhexis margin nasally, which overrides the square edge optic of the lens. And once this is hidden by the optics of this, by the rounded edge optics of this secondary lens, that seems to go away almost immediately. The ND ring also serves a similar purpose. One other way to do it would be to do a YAG laser. Obviously, in this case, I did not want to do that because patient had an excellent visual acuity outcome and did not want to compromise that, but disturbing the lens in the back, and so chose to put in a second lens. You already saw it in a different scenario. This is the primary lens, this is a secondary lens, and this is separation. This is because of the particular angulation of this lens, and this is the ASOCT pictures which is showing the two lenses. One of the commonest problems that we have is excellent results. Optometrist is happy, surgeon is happy, the lens looks great on the patient's eye on the slit lamp, but the lady is most unhappy, and she'll go around. Mind you, it's not the industrialist who will spoil your reputation. This lady who will go around telling each and everyone who is willing to listen to her in a colony, in a family, telling that before the surgery was much better. And quite often, in spite of an excellent visual outcome, is that dry eyes which is the problem. And often the patients obviously do not complain of dryness of the eyes always. Whenever they have fluctuating vision, photophobia, fatigue towards the evening, increased mucus material, and when you stay and you see a picture like this, you should suspect this. Almost 70% of the patients who present to us for cataract surgery are predisposed to dryness. And the most important factor you must remember that is when you're dealing with a situation of dry eyes, post-operative medication, less is more. The less you prescribe medicines, the lesser are the chances that the patient will present with the post-operative dryness. Pardon me for the trade names being mentioned because it's a screenshot of the actual prescription. As you can see, what we give is just four times a day, 2 weeks of moxifloxacin dexamethasone combination. After that, completely withdraw that. Then two times a day, NSI drops for 6 weeks, and plenty of non-preserved carboxymethyl cellulose eye drops. You could use other lubricants also. And once you do this, at least the run-of-the-mill cases seem to do well. At least you would not be inducing dryness in these patients. Obviously, it's also, I think most of us have made it mandatory to have a look at the retina, not just by indirect ophthalmoscopy or direct ophthalmoscopy at 90D, but also doing an OCT. And you can see a epiretinal membrane like this. Very often, a casual retinal examination by anterior segment surgeon could miss all these problems. And whenever you do a cataract surgery with or without a premium IOL, obviously this would lead to a suboptimal outcome. And forewarning these patients about this, and then uh, preparing them for this and addressing it properly would be a good idea to deal with this. This is something that I have whenever a patient of multifocal intraocular lens complains of dysphotopsia. Very often it's an observation and not a complaint. I have these -2 diopter lenses, ask them to wear this and try to read. Immediately they understand there is a much to be gained. I say I can replace it with a monofocal intraocular lens, but this is what you will get if I replace it. And immediately they understand the value that has been brought in, and quite often they delay or just postpone. So far, in more than 15 years of putting in multifocals, I have just removed a couple of lenses for the reasons of dysphotopsia. This was already mentioned by Chitra. This is again emphasizes the importance of doing a correcting cylinder whenever you faced with toric multifocal implant. Initially, we had done a symphony toric. Patient was quite happy, but then, as you can see, it's a 6 by. He required a near correction for as far as near vision is concerned. So essentially, instead of a EDOF toric, the patient received a trifocal toric in the second eye. So it bilaterally implanted, the patient ended up with optimal results. And neuroadaptation is also the problem as well as the solution. Whenever the patient has a problem and you find everything is normal, you counsel the patients to wait it out, and most often you find that in 6 months down the line, you end up with a happy patient. And the final slide, but perhaps the most important slide, is that whenever a patient comes to you with a postoperative problem, please do not get aggressive. Agree with the patient. Tell them that you know this problem could be there, this is going to settle down, prescribe them whatever medication, counsel them. Once they understand that you are with them and your reassurance is there and you can promise a solution, most often half the problem disappears. Thank you so much for your kind attention.
Thank you, sir. Thank you, sir. That was a wonderful presentation. It's very difficult to sum it up all in 7 or 8 minutes. And what you said is true. Patient is always right. You have to take it. Just one question regarding the NSAIDs, especially in severe dry eye, it produces even corneal melt. So do you find any difference between these various molecules like nepafenac or bromfenac or even high dose nepafenac? Which is the best?
We have been using this Nefenac most often, and I don't really find any big difference between any of these molecules. And one thing is that whenever there's severe dry eyes, I was essentially talking about run-of-the-mill cataract cases who have a problem, and we don't want to induce dry eyes. But if the patient presents with severe dry eyes, maybe I would avoid using a NSAID drops in those cases.
One small tip regarding centration of multifocal lenses. After you finish implanting the lens, just ask the patient to look at the light and you just coincide it with the Purkinje image. So if you find the center is coinciding with the Purkinje image, it's as good as the center, the central ring. I'm telling about the central ring.
I completely agree with you. I also do that. But I think that's more for our satisfaction rather than any true benefit, because for the simple reason, all the lenses that we implant are about 13.5 millimeter overall diameter. The capsular bag is just about 10.5 millimeters. So the lens essentially sits depending upon the dimensions of the capsular bag, and even whatever position you leave it finally is going to settle down in a position where according to the dimensions and the direction of orientation of the lens. So, but if it's a well done surgery with a regular 360-degree overlap, you find that especially with the 1.4, 1.6 millimeter central ring, it centers quite well.
Thank you, sir.
Thank you.
One more question, sir. You put that piggyback lens for that. That's a single piece lens. Is it advisable to put it in the sulcus?
There are certain variations in the sense it's a hydrophilic acrylic lens, not a hydrophobic. The square edge is not a square edge but rounded edge. So the chaffing of the back of the iris is not there, and the entire even the haptics are quite soft and undulating. And yes, it's not a good idea to put anything in the sulcus, but then this is much better than having a hydrophobic acrylic with a square edge.
Thank you, sir.